done that. Right? It's abducted away from the body. Now, when we're looking at the ulnohumeral articulation, this is a saddle joint, right? Pure saddle joint, so there should be 2 degrees of freedom. The second degree of freedom would be this add and abduction rock. Now, typically this is restricted by the connection to the radius, right? So this is really more of a conjunct motion than it is a pure degree of freedom. But what the joint surface will allow are these medial to lateral glides of the ulna on the humerus. Okay? So now we're dealing with a convex surface, right, as the ulna. So these motions are going to go opposite, right? So to get into an abduction position, what has to have happened is the ulna has to have shifted medially, right? So to confirm this abduction, what we want to do is we want to bring her into this position and try and produce a lateral glide of the ulna on the humerus. And you can probably see this here. Let's see if I can turn her on a little bit more. That is the amount of glide that we get, which is next to nothing.
So for that versus like your ulnar collateral ligament testing, you're just on the ulna instead of on the joint line, or?
I'm basically right over the joint line. I mean, if I wanted to come in here and fix the humerus, I guess I'd have to fix it like this and actually get on the ulna and try and produce the glide. It's going to give me the same result. But if I'm directly over the joint line, I'm going to get the same idea. Okay, so what does this do to us, right? There is a fair amount of medial and lateral glide here at that ulnohumeral articulation. And what it will do, because it is a conjunct movement of flexion and extension, is if it is present, it will affect flexion and extension, right? And it will affect these end ranges of movement. So there are all kinds of different pain patterns, pain profiles that will come in with as a result of an abducted ulna. Okay, we can develop medial elbow pain from excessive stretching there of either the ulnar collateral ligament or potentially the flexor mass. We can develop lateral elbow pain from compression of the radial head into the capitulum. We can develop dorsal wrist pain, right? Prolonged compression of the radial head will eventually shunt the radius distally down into the wrist, right? So what happens is the radius will shift into the wrist bones and block wrist extension and radial deviation. So we'll get an impact issue, an impingement issue here on the posterior side of the wrist. We can get a tendinopathy here at the lateral elbow as a result of the extensor tendon. The extensor's trying to produce wrist extension against a blocked joint. We can get ulnar-sided wrist pain. As this pushes down into the wrist, we are either going to get an ulnar deviation, which could cause excessive compression of the TFCC, right? Or we could get a shunting of the entire wrist that will increase the amount of tension on the ulnar collateral ligament of the wrist. We can get palmar wrist pain. As the radius shifts into the carpals, one of the compensations that the body will make is it'll push the scaphoid into the palm of the wrist, which will put tension on flexor retinaculum. It'll put tension on the tendons, etc. All the soft tissues here in the palm of the wrist. Put tension on the joint capsule that's associated with that scapho-radial articulation, etc. So we can have all kinds of issues here that develop as a result of this particular problem. We could have paresthetic sensations from tension on the ulnar nerve. I've had patients come in with radial nerve tension, because the radial head will end up not just shunting, but it'll actually shift forward as the radial nerve comes across the front of the radial head. So all kinds of stuff, right? This is why the quadrants, again, are one of the first tests that I go to check the elbow. Right? Because if I have, this is my lone quadrant loss, well, I'm pretty certain it's going to be an abducted ulna already. All I have to do then is I have to go in and do my ulnar glide, lateral glide, to confirm. Right? Yeah.
Can you see that just by having them do that?
Sure. Yeah. I mean, one of the other things you can do is you can have them show you their carrying angle, and they should be off more on the affected side. I've had patients in the past where you're able to look straight down the middle finger, and what you'll see is you'll see this deviation, right? So it'll look like this. But that's not always the case. If we have the full shunting of the whole wrist, it'll actually self-correct itself. So you can't really rely on that as a diagnostic thing. What we will do is we'll often look at position of the radius relative to the ulna here. There we go, that's better. So there's the end of the ulna, there's the end of the radius. And what we should see is they should be relatively symmetrical. Right? So if we're seeing a substantial difference there, and I would say substantial would mean almost an inch of difference, that's not normal. Right? These two things should be a relatively flat joint here. Yep.
So with an abducted ulna, it's medially glided.
Yes.
And then you want to do a lateral glide to.
Yeah, so the correction would be a lateral glide, right? So because we're dealing with a convex on concave surface, that's the direction things will go, right? So that's kind of the testing for that right there, right? We can look at wrist extension, which will be usually somewhat limited if there, and there it is right there, you can see it where it's impacting. We can look at radial and scaphoid alignment. So what we should see is we should see them in pretty much a straight line going across. And what we would see is radius being here, scaphoid being down here. So it'd be like that, kind of like that. So it'll be a bit harder to see here from this angle. There's her scaphoid, there's her radius. So that's off. Okay. So again, pretty common profile. Now, can you have an adducted ulna where it goes in the opposite direction? Physiologically speaking, yes. Have I ever seen one in a clinic? No. Far more common to have an abducted ulna. Some of the things that can cause this, those of you that work with overhead athletes, if you have restriction through the shoulder girdle, something where they're not getting into a good closed pack position to throw, you're going to abduct the ulna down here. It happens a lot. You can have it from a fall on an outstretched arm, right? You can have this from people just working out in the gym, people doing pressing motions, things like that, where it'll actually shift on them in order to create some stability. So all kinds of little things can cause that sort of stuff. But you'll find that you'll be able to treat a lot more patients by being able to recognize this lesion than what you ever thought was possible with the elbow before. The elbow, for most cases, even though it's a compound joint, 3 different joint cavities within the same joint capsule, it seems relatively simple, right? Like, well, if we have a loss of flexion or extension, we'll work on that. If we have some tendonitis, well, we'll work on maybe the wrist a little bit, and we'll work on some grip strength, things of that sort of nature. Well, there are biomechanical problems that occur in the elbow in itself, right? And so being able to correct what typical biomechanical problems there are, it's going to make you more efficient. It's going to make you a better therapist in the long run, right? So that's kind of the cluster, right? So you're going to want to look at the carrying angle. You're going to look at flexion, supination, abduction, quadrant. look at the lateral glide for adduction, which should have a pathomechanical end field. And then you're going to want to look at radius position. You're going to want to look at wrist extension, scaphoid position. You should, in theory, also have some sort of limitation of pronation or supination. Now, it will tend to depend, it'll vary depending on what has actually happened with the radial head. Right, if the radial head has gone anterior, you're probably going to have a loss of pronation. If the radial head has just shifted distally, right, so it's shunted distally, you're probably going to continue to have a limitation of supination. But that's a bit variable, depending on what the radius does. Okay, any other questions about that? All right. So